Chabot is going to be the first kind of the basics, the elements. He's a brilliant scientist, and he's been here longer than I have as well. So very experienced in this. So take it away, Jeff.
All right, thank you. All right, so good morning, everyone. So as you can tell from the letters after my name, I'm not a clinician. So what I'm going to kind of do is sort of do a quick, almost 30,000-foot view of a lot of the different modalities that you're going to hear later on. I'm going to focus on sort of the basics of them, and then you'll hear later on, more exposition on, sort of the practical. How do you make this work for you? How do you identify the right patients, and so on. A few disclosures. Okay, so the outline, I'm going to go through, touching on how the immune and what I call the regenerative systems interplay with each other. And then we're going to start hitting these modalities. We're going to talk about when you use blood, to get PRP, what you can do with it, exosomes from the blood, alpha-2 macroglobulin from the blood. Spend some time on bone marrow, very briefly on adipose. And then a couple of sort of extra things, if we have the time, talking about sort of treating joints holistically, and a really exciting new area that's kind of popping up called Muse cells. Okay, but first, a basic question, okay? Why aren't we all dead all of the time, okay? I mean, with apologies to Abraham Lincoln, some of us are dead all the time, and all of us are dead some of the time, but why aren't we all dead all the time, right? The world is basically constantly trying to make us dead. We have pathogens that can make us sick. We get injuries, and even if you hermetically seal yourself up in bubble wrap, you can still have spontaneous things like mutation that lead to cancer. So my short answer to why we're not all dead all the time is the interplay of the immune system with the regenerative system. And basically, after you have some kind of damage of whatever kind, there's three sort of steps that you go through. So step one, clear out the damage that's already happened, okay? And this is largely a function of the immune system, and this happened by inflammatory pathways with monocytes, macrophages coming in, kind of gobbling up the debris and sort of trying to clear the area so that a repair can take place. Then you want to prevent further damage and orchestrate an orderly transition from this sort of inflammatory phase to a regenerative phase. And that's where the immune and the regenerative systems are really interplaying with each other. And then finally, repair the damage and return to a healthy state. And this is going to be guided by elements of the regenerative system. But sometimes this process doesn't proceed smoothly on its own. Most of the time, most injuries we heal from, most illnesses we heal from. But sometimes this doesn't work completely or it doesn't work efficiently, and that's where we're going to step in and say, what can we do to sort of help each of these steps in order to facilitate the overall healing process? So what are the tools that regenerative medicine can bring to help with each of these steps? So with clearing out the damage, by the time we would get involved, often this is already underway through the inflammatory process. But we can assist it with techniques like needling and wound debridement. You could use stuff like shockwave treatment to try to break up calcified or scarred fibrotic tissue. I'm not going to spend really any time in this presentation on this first step. The second step about preventing further damage and facilitating this transition to a healing state, this is where a lot of regenerative procedures come in, right? Where we can use anti-inflammatory exosomes to try to tamp down that inflammation and bring forward the next phase. Alpha-2 macroglobulin can stop further tissue degradation. And then tools like probably the workhorse of regenerative medicine thus far, platelet-rich plasma, to call in cells to help fix the damage. And then finally, the stage where you're actually guiding the repair. We can use things like PRP to try to tell your body to send these cells in, or we could actually put the cells there ourselves if we want to make sure that they're getting delivered in high quantity and quality. And we can get those from bone marrow, we can get those from adipose. And you'll hear about those later. Okay. So kind of jumping in, platelet-rich plasma, PRP. So how does it work? So if you start with blood, it's going to have a mixture of things, a lot of red cells, but also some white cells and some platelets. So what we're going to do is selectively isolate the components that are going to help us with what we need to help the repair. Okay, so we don't really need the red cells. The liquid, the plasma itself has some benefit, but mostly what we're trying to catch are the platelets and some, not all, but some of the white cells. So as you prepare your PRP, you can try to just collect the platelets, okay, and sort of leave out a lot of the white cells, and we call that leukocyte poor PRP, or LP PRP, you might see. Or we could actually also grab the white cells themselves, and then we would call that leukocyte rich PRP. Okay. When you take this and you administer it where there's an injury, okay, the platelets themselves have sort of a natural stickiness, and this basically creates a focal point from which you will get the release of growth factors and signaling molecules that are coming from the platelets. And those are going to sort of establish a gradient that other cells, these MSCs that we'll get on talking about in a second, are going to sense that gradient and say, hey, I need to go there and I need to cause something to happen. MSCs, that's an acronym you're going to see a lot today. Originally, these were called mesenchymal stem cells. But then with further refinement of the understanding of their role in the body, a stem cell properly is one that turns into other cells, right? It's kind of the root of the tree. These cells, they can differentiate into other cells in vitro, but in vivo, that's not their role, okay? Their role is to basically come in and help direct the cells that are already there to alter their behavior, to proliferate, to whatever, to fill in the injury. So they were renamed medicinal signaling cells, which was handy because we could keep calling them MSCs. Okay, here they come. Very good. And these cells are basically going to do the workload of finishing the transition from inflammation to remodeling and repair and to help engineer the healing response. So what are the keys for success when you're dealing with PRP? Okay. The concentration of platelets, the concentration and the dose, I should say, of platelets is going to be critical. Also the cells if you're doing a leukocyte-rich preparation. So if you think about it, roughly the way to think about how much am I concentrating, well, what was my starting volume and what's my final volume, okay? But then also importantly is the percent yield that you get, right? You can reduce the volume 100-fold, but if there's no cells in it, you don't have a good treating composition. So we want to start with high volumes on the top. We want to reduce as much as possible with a little asterisk that if you're going to be injecting into a space that is, 10 mils in size, if you reduce your volume down to 1 mil, it's just going to dilute itself as soon as you put it in. So factoring in the size of the defect, helps you sort of figure out where you might want your final product to be. And of course, use a process that very efficiently captures the platelets and the cells if you want those. The different things that are in the PRP, the platelets, of course, are going to be very good with anti-inflammatory factors and those signaling molecules. The leukocytes are a more complicated story, right? So you've got neutrophils and monocytes. Those tend to be helpful. You can also have granulocytes, which can be pro-inflammatory. So it's a more complicated sort of cocktail of cells. But overall, these are, if you include the leukocytes, that in many cases is going to be more efficient at driving the healing. So how many platelets do you need? What kind of fold concentration should you be driving for? It is somewhat age dependent. Part of this is that platelets may become less abundant as you move on in age, so you need a higher fold concentration. Part of it is also that older people need more help to heal. Again, all of these slides are on your stick, so you can take pictures certainly, but you'll also have all of them when the presentation is over, as well as all the references. Okay. So do you want to choose a leukocyte poor or leukocyte rich PRP for your treatment? And so I kind of divided things up into some very rough buckets, and there's going to be exceptions to all of these. But if you're going with leukocyte poor, if you're dealing with something like acute pain management, not so much trying to fix an injury, okay? But a lot of this could be driven by inflammation. Leukocyte poor could work great. On the other hand, if there is an injury, you probably want the cellular content to help fix that. So you want to think about leukocyte rich. Older patients, often their problem is chronic inflammation, and the anti-inflammatory, very potent anti-inflammatory properties of the leukocyte pore may be enough for them. For younger patients coming to see you, it's probably because there is an injury, there is a defect, and so the leukocyte rich might be better for them. If there's joint damage, you have to think about, do I want to put cells into this joint? And sometimes the answer may be yes, but often the leukocyte pore might be the better way to go. And the leukocyte rich, certainly if you have extra-articular injuries, you know, where you're not worried about putting the cells there. In fact, your point, the goal is to get cells to go there. So in a lot of cases, that would be appropriate there. So exceptions are going to exist for all of these different cases that I've roughly bucketed out here. But there's one key thing that's always going to apply, right, which is that the dose and the concentration are the most critical factors for success. Okay. A couple other things that we can get out of blood. So exosomes, a lot of hype about exosomes and well-deserved over the past several years, I'd say especially. So cells have a lot of ways to communicate with each other, right? They can release proteins to signal to each other. You can have direct membrane-to-membrane contact. But one of the very clever and powerful ways that cells communicate is by basically taking little bits of their cytoplasm, which contain all kinds of things. They can contain proteins, they can contain regulatory RNAs, and they bundle them up in little lipid blobs, fire them off, and then they can fuse with another cell, and now this cell can alter this cell's, say, gene expression by doing this. And it's you can have these very complicated and sophisticated messages because it's not a single protein, it's not a single RNA. So if the cells that are producing this are, say, generally trying to promote an anti-inflammatory phenotype, then the balance of the message contained within the exosomes will be anti-inflammatory. And so, what cells produce anti-inflammatory profiles? Well, these MSCs do. There are cells in dental pulp, which people have tried to produce exosomes from, amniotic fluid. If you produce exosomes from these, or capture exosomes from these, they're generally going to have a very strong anti-inflammatory message. But, and I have to put an asterisk because we're in the state of Florida now, which makes it the Wild West. But generally, the FDA has heavily restricted the use of exogenous exosomes. This is true for most regenerative treatments. Autologous, great. Exogenous, gotta be careful. But there are devices and there are methods about, and you'll hear about one of those methods in about an hour, I guess, for how to produce exosomes or capture exosomes from autologous sources. So as you're making your PRP, grab those exosomes, mix them in, and really boost the potential of the PRP treatment. Okay, so basically I just said this. So exosomes in circulation tend to have an anti-inflammatory profile. And the way I like to think of this is, so you've got the body, you're represented as a pink line, and what you want to do is you sort of want to have a basal anti-inflammatory tone. So not, as soon as you have a single, inflammatory protein or something, you don't want that to kick off a cascade. So you sort of have this basal tone of tamping down inflammation. But now when you have an injury or something, the inflammatory signal exceeds that, that level of suppression, and now you get localized inflammation without having the whole body, going to hell. So what we're going to do is take this basal tone from, however many milliliters of blood, we're going to concentrate it down and basically raise the level of the anti-inflammatory message just at the site where we're administering it. And in this way, we can tone down that that inflammatory signal. That's what we want to do. Okay, and then hopefully shut that off. Okay. Another protein, people have been working with this for a number of years. A really huge protein, 720 kilodaltons, which is big, called alpha-2 macroglobulin. Its purpose in the body, or the purpose that we mostly care about, is that it can bind to things that degrade extracellular matrix. Okay? Things like RMTI proteins or matrix metalloproteinases. It can also do some other things, but that first one is really what we're focused on. So when you have an injury and there's this, as I was saying, sort of this ongoing degradation, we want to stop that. Okay, put a halt to it, and then let the healing proceed. So there are tools that you can use out there to concentrate alpha-2 macroglobulin from your own blood. And so when you administer this, basically you're going to hopefully shut off this further degradation at the site where you've injected it. So, and actually some of the same tools that are used to produce exosomes will actually also concentrate alpha-2 macroglobulin. So, prevent further degradation of the ECM. Okay. So shifting away from sort of the blood, I'm going to move over to marrow now. So a lot of what we're doing when we're dealing with blood and blood-based products is about signaling molecules. When we switch to marrow, now we're focused on a cell-based product. We're not delivering the cues to bring the cells in, we're bringing the cells there ourselves. We're kind of jumping a step in the line. So these cells, especially the MSCs that are contained within marrow, they're going to release cytokines, they're going to sort of touch the cells that are there at the injury, and they're going to orchestrate this transition into a healing stage, and they're going to tell the cells that are there, you need to fill in the defect, you need to rebuild this fiber, you need to tell them what they need to do and move them from their normal sort of non-proliferative state into a remodeling and healing state. Just like with PRP, if you're dealing with marrow, dose is going to matter. Make sure you've got the right number of cells, and everything is what I already said. So how many cells do you need, okay? So some nice studies have been done where they actually treated a number of different conditions, but then looked back at the material that they started with and said, how many cells did we have per milliliter? Typical way that people do this is by basically taking a plate, streaking it out, and then seeing how many little colonies can form, right? If a colony is forming, it's because you have some cell there that can proliferate. Those would be starting off as the MSCs anyway. And there's a pretty clear pattern that you can see where, these procedures that ultimately ended in success have more cells than the ones where the procedures were deemed to have failed. The numbers, the absolute numbers, kind of drift around a little bit, mostly probably due to differences in how people are doing the counts. But one thing that's pretty clear is you want to be up in these, sort of thousands of these CFUFs per milliliter. And if you just do a standard bone marrow aspiration, you're not going to get enough cells to do that. The reason for this is, and there's some stuff in the backup slides that I won't go through, but when you put a needle into a marrow space and you do a pull, you get really good marrow. As you keep pulling, what happens is, nature doesn't like a vacuum, so the blood vessels within that are feeding the marrow space are going to start rupturing, and basically peripheral blood is going to fill in that space where you were just pulling out marrow. So as you keep pulling, you're sort of getting diminishing returns. Okay, mostly what you're pulling is peripheral blood. So the analogy I like to use is thinking of if you have like a snow cone, right? If you just put the straw in and leave it in one place, right? The first sip you take is going to taste like blue raspberry or whatever. But then if you just leave the straw there, after a while, you're just going to be having icy water. You got to move the straw around, or use a centrifuge-based tool in order to try to concentrate the cells down. So you can use centrifuge systems to increase the counts, and you can see that, yes, in fact, if you start with this number and you use centrifuge system number 1, you can get it up over 1,000, that's great. This one takes 200 up to 500, could also be good. But this comes at a cost that you lose a substantial number of cells as you're doing this. And part of the reason for this is, remember, these cells, the MSCs that we're most interested in collecting are proliferative cells. So therefore, they're at all the kinds of different stages of the cell cycle. And so some of them are going to settle out in the red layer, depending on where they are in the cell cycle. So you're going to lose those cells if you try to just sort of capture this bumpy coat where you have most but not all of the cells. And the thing is just healing is a function of cells. It's not a function of densities. So when you use anything that's going to try to separate things based on densities, are you really capturing everything you need, or are you just capturing what is convenient to capture? There are systems that are out there with the disclosure that I had a hand in coming up with these, where just like the analogy with the snow cone where you move the straw around, basically you move the marrow needle around so that you can explore an extended geography and take little sips here and there and end up with a high quality, high concentration product just right in the syringe as you're doing the aspiration. And you'll probably see some of these devices demonstrated during the labs this afternoon. Okay. And so the nice thing is when you look at the CFUs that you get out of straight from the needle, you're up in that 2,000 to 4,000 range generally. And if you recall the table that I showed a couple of slides ago, those are numbers that are associated with success. You don't even need to put it into a centrifuge. You're getting all the cells. It's by definition 100% recovery because you're not separating anything out. You get cells other than MSCs that can help play a beneficial role. So you don't need a ton of excess anticoagulant because it doesn't have to sit in a centrifuge for 10 minutes. Okay. One question that has come up a bunch of times is, do I have to worry about, if I'm dealing with marrow, if I'm dealing with PRP, there's probably going to be some red cells in there. And we know that if you get red cells in a joint space, right, so think of like hemophiliacs who routinely bleed into their joint spaces, this can cause, as the cells die, they cause oxidative stress, this can cause damage. So do I have to worry about putting something that may contain red cells into a joint space? So this was a nice study. This is in a canine model. In this study, they were basically injecting one knee as a control, and the other knee they would inject, and they would inject it with either whole blood, well, let's just focus on the whole blood. So this isn't any kind of treating composition, right? It's just putting blood in there. And you can see that if you repeatedly do the injections where you see these arrows, that basically if it's bad to go down, it goes down. If it's bad to go up, it goes up. So it's not good to repeatedly introduce blood into a joint. However, in the same paper, they checked to see what happened if you just did it once, okay? And if you just did it once, you can see there's a sort of a transient response that's not great, but it goes away over time, okay? So, and this intuitively makes sense, right? Everybody's banged their knee at some point. We don't all need a joint replacement as soon as we bang our knee. So, their conclusions were that if you just go once, you're probably okay. And you're probably talking about hopefully you're treating somebody once, maybe twice, and then being done with it. So you don't, it's good and proper to say, am I doing the right thing for my patient by introducing something that may have red cells? But again, if it's not going to be a chronic treatment, then it perhaps is not the highest concern or detriment. And again, as I mentioned, this was just injecting whole blood. You're hopefully injecting something that's not, you're just not looking to see that it didn't cause damage. You're introducing something that's going to help. And to that point, here's another paper that was done. So this is a horse model now. So a full thickness defect was introduced, and then in the cartilage of one of the animal's joints, and then was treated with microfracture. Basically take a little drill and drill holes through the cartilage into the bone space underneath. This can allow cells from the marrow to come out into the cartilage space and hopefully help fix the repair. So one joint was treated with microfracture, and so you can see that there's some healing that's gone on there. But here's another joint which was treated with microfracture plus introducing marrow directly into this space, not forcing it to come up through the microfracture. And you can see the healing on the right looks better than the healing on the left. And the reason I point this out is that when you put the marrow on top of the microfracture, you're actually adding more red cells, right? There's red cells in the marrow. But that extra healing content, the cellular content of the marrow is helping to drive healing even though there's more red cells there. Okay. A couple more things about marrow. As we get older, okay, when you're born, all your bones are full of red marrow, right? That's the good marrow that contains the MSCs in high abundance. As you get older, and not much older, the red marrow starts to retreat, sort of to your axial skeleton. And there's a picture here. And it doesn't take very long for this to start happening. So by the time you're an adult, maybe 25 years old, you really have to go to, again, sort of the axial skeleton here in order to get good marrow to treat with. And the other bones are now full of what we call yellow marrow. It's mostly fat. If you did an aspiration from there, it would look red because there are blood vessels, so there are going to be blood cells. But what you're getting there is not the quality of marrow you would get if you went to, say, the hip in order is mostly where people go to get marrow. And the other thing to note is that without the red marrow around these joints, okay, the joint is no longer the complete and healthy organ it was when it was when you were much younger, okay? And this is starting to get to the point where people start having problems with your joints, right? You don't typically see this unless something horrible has gone wrong, in youths having highly degraded joints. Okay. Trying to move things along here. So you can get good marrow counts out of people if you go to their hips, even in at a somewhat advanced age. So don't let age be a detriment as long as you collect from the hip. Okay. Just one slide on adipose. So adipose also contains MSCs, and when we get them from adipose, we call them ASCs, adipose signaling cells. They're present at much higher concentrations actually than they are in the marrow. And this is probably reflecting that adipose is a very dynamic organ, right? It grows, it contracts, and it has to adjust its vasculature, you need angiogenesis and so on, proliferative functions. And also it's a shock absorber, right? So its job is to one of its jobs is to take a beating. That means that you can get trauma in there that needs to be repaired, and so you have a high concentration of cells that can help do that fixing. You'll hear more about adipose later from the rest. And I asked AI to make a picture. So there's two kinds of adipose roughly in your body. There's subcutaneous, sort of a pinchable fat, and visceral adipose that goes around your organs. Visceral adipose is bad, bad, bad. Okay, so when you do your treatments, you're going to want to be using subcutaneous adipose. This image is so terrible that here's the spine. You can see that the stomach is clearly labeled liver. So I was like, you know what, I'm going to use this picture here. So use the sub-Q, don't use the visceral, and I now believe it's going to be at least several years before AI takes all of our jobs. Okay. Okay, with the couple minutes I have left, I love these studies here for several reasons. So there's one of the guys who's kind of one of the pioneers of regenerative medicine, Philippe in France, has been working with mostly marrow for a very long time, but that also means he has a lot of follow-up time on subjects that he's treated. So here's a study where you had people came in, they said, I have two bad knees, I need to do something. So he randomly treats one knee with injecting marrow into the bone on either side of the knee, okay? Which sort of seems weird, marrow comes out of bones, why are you putting it back? But remember that around your knee, when you get older, there's not red marrow. So you're putting red marrow there and sort of restoring, at least partially, what the joint looked like when it was younger. And on the other side, he does a joint replacement. And so following up, average of 12 years, 6 out of the knees that were replaced needed subsequent surgery. Only one that got the marrow injection needed a follow-up surgery. So that's kind of interesting. And just when you ask the patients which one feels better, 21 out of the 30 preferred the knee that had gotten the marrow. 9 preferred the knee that had been replaced. But if you, it's important if you're going to try both of these things that you try them in the right order, because once you replace the knee, you can't do the marrow thing anymore. Seems obvious to say. But yeah, and why does this work? Because you're making the knee look more like it did when it was younger and when it was healthier. Another study, very similar results, but this was people who were older, okay? And they found that, you could go, 10 years after getting the cell therapy with really no need for any kind of further intervention. And when we're talking about people who are older, that might get them most of the way. So that would be, really great, and with a procedure that's much less invasive than a replacement.
Is this for severe or moderate arthritis?
So that's one of the, and the docs may comment on this too, identifying who are the right patients. I mean, some people are so far gone, there's nothing left to regenerate. And so, identifying who's going to respond the best, and being honest with people in terms of we could try this, but there's no guarantees, because of the amount of degradation. Setting people's expectation levels is going to be important, and you'll hear more about this from the docs later. Okay, and I do want to spend 1 minute on this because I was told I had to spend a minute on this. So Possibly the next wave in regenerative medicine are these cells that are called Muse cells. These were quite accidentally identified, as many breakthroughs have been. And what these cells are is they are actually a true stem cell, okay? They have differentiable potential not only in vitro but also in the body, okay? These cells are tough to kill, which you would expect from a stem cell, and they can differentiate into all kinds of things, all the different derms, right? Your endo, meso, ectoderms. And they proliferate slowly in culture, but they have properties that enable them, as they're proliferating, to maintain their stemness. One thing that you can worry about when you proliferate cells outside the body is this going to cause some kind of tumorigenicity down the road? Are you selecting for cells that are really good at proliferating in not their natural environment? These guys have all kinds of mechanisms to help them avoid that. I wrote a review of kind of the literature of it. You can access, there's a link, it'll be on your stick, to the ACC Bio webpage where you can read that. But I just want to highlight these cells in very small studies. I mean, these are all basically pilot studies, lots of different indications. You inject these things intravenously, they find where they need to be, where they need to go, and they had some really, not all the time, there was some questionable efficacy, but overall there were some really impressive results that they were able to get in small studies, not all placebo-controlled, et cetera. But this is something that I'm definitely going to be keeping my eye on as we go forward. You know, could this be sort of the next frontier in regenerative medicine? Going one step beyond, let's bring in cells to guide repair. Let's put the cells there that are going to become the repair, right? It's kind of what people think of when they think of stem cells. Okay, there's a ton of references. There's some extra material in there that you can peruse if you're interested. So thanks. And